Okay. Okay, good morning, everyone. Let's go ahead and get started with today's grand rounds. And so before I do that, before I introduce today's speaker, just a few housekeeping comments. As all of you are aware, this is being live streamed via live stream Facebook and YouTube. So if you have any questions from the audience, please make sure we use a microphone. We'll have a post-Grand Rounds live broadcast interview with Dr. Rao at 9:45. So if you have any questions that you want to submit on the back of the flyers, please do that. Couple of upcoming conferences that I want to announce. There's the second annual Critical Care Symposium, which will be January the 18th. The fifth annual Houston Heart Failure Summit, which is February the 7th. The third annual Heart of a Woman Conference, which is February the 15th. The inaugural DeBakey CV Congress Conference, which will be February 26th and 27th. And then the 10th annual Multimodality Imaging Conference, which will be held in Fort Lauderdale this year, which is March the 14th to the 16th. And obviously, Dr. Kleiman would not let me go without announcing the Interventional Journal Club, which Dr. Rao will also be at this evening at Antigua, Osteria, right? All right, so let me introduce today's speaker, and I think he's really someone that's very well known in the interventional world. And I was actually fortunate to know him when we were both fellows. He was doing his cardiology fellowship, and I was doing my cardiac MRI training at Duke. And Sunil, I think, was a third or fourth year fellow at the time. And even then, I knew this is somebody who's going to go somewhere. And he's had a tremendous trajectory in his career. To give you some background, so he's currently professor of medicine at Duke University Medical Center, and he's also the section chief of cardiology at the Durham VA. Sunil originated in Ohio. He went to med school at Ohio State, and as someone who used to live in Michigan at the time, where there was this big rivalry, we won't hold that against him. But he quickly left Ohio and went down to Duke, where he did his internal medicine, cardiology, and interventional cardiology training, and was actually the chief fellow at the Duke Clinical Research Institute as well during his time there. Sunil has had a tremendous rise in the 15 or 20 years since I knew him as a fellow. He now is actually the editor-in-chief of CERC Cardiac Imaging, or CERC Cardiovascular Interventions. And so I'm sure there's a great opportunity for the fellows when you meet with him during lunch to get some insights from him on that experience. Sunil is really a national expert in acute coronary syndrome, as well as bleeding and platelet and blood transfusions. And he has over 250 publications. He's the co-editor on a seminal textbook on transradial procedures. He's actually been here and helped set up transradial procedures here as well. And without hearing any more from me, I think what you want to hear from is Sunil. So let me bring up Sunil Rao, who's going to talk to us about improving the safety of PCI, trials, tribulations, transfusions, and then obviously Twitter. Thank you, Sunil.
Thanks so much. It's really an honor to be here, and I should take this opportunity really to do two things. First is to remind Dipan that it's the Ohio State University, and the second is to apologize to him because I think my attendance on that MRI rotation was probably a little uneven when I was a fellow. So thanks again for this great opportunity. It's a real pleasure to be here. I want to take you through some of the things that we've been working on over the past 2 decades or so, some of which started out and was pretty unpopular at the time. It was very challenging to get any of these data published in the peer-reviewed literature. And then eventually, I think, as the therapeutic options increased and people started paying a little bit more attention to some of the outcomes, has become a little bit more accepted in the clinical community. These are my disclosures. I don't have any consulting relationships with industry. Any industry relationships are really related to research funding. So I want to take you back. I guess I'm old now. I mean, I was an intern in 1996 at Duke. And, for those of you who don't remember this time or weren't around, these are pretty heady days back then in PCI. So this is early days of coronary stenting. We had the cardiology fellows had to fill out a form every time they put a stent in, justifying why they put a stent in. It was always the same justification, dissection, but they still had to justify it. And the idea around angioplasty and acute coronary syndrome at that time was that the ischemic event rates were so high that we had to use every tool in the toolkit to prevent recurrent ischemia. And the tools really were around antithrombotic therapy. And some of the things that we were using back then, have been relegated to the trash bin of history. I mean, dextran, patients got dextran. A lot of patients after coronary stenting got Coumadin. So the bleeding event rates were quite high. And I was an intern on cardiology in October of 1996. And every patient got all of these anticoagulants. And it always seemed like when I was on call around 2 o'clock in the morning, 2 or 3 patients had a major bleeding event. It was either hematemesis, or they had a gigantic groin hematoma because we were using 7/8 French sheaths back then from the femoral approach. And I just remember thinking to myself, that doesn't seem right. I mean, it seems like there's got to be a better way to do this to preserve the ischemic benefit and reduce the bleeding risk. Of course, we didn't really have a lot of options at that time. Now, as things progressed, I was a fellow at Duke in 1999. Things got a little bit more sophisticated. Catheter sizes went down. This is the heyday of 2B3A inhibitors. So I think like the irrational exuberance that we continue to exhibit for a lot of new therapies, there was a lot of irrational exuberance around 2B3A inhibitors, certainly at our institution, where we had done some of the trials around 2B3A, and we were doing primary PCI. And I remember as a fellow, so I don't know if many of you have been to Durham, North Carolina, but there used to be a blues festival in Durham every year. And we had a patient admitted with a large anterior MI who happened to be a blues musician, and he knew Muddy Waters and B.B. King. And so I was talking with him after he had undergone his primary PCI. He was getting an infusion of abciximab. And right in the middle of our conversation, his eyes rolled back in his head, and he basically stopped talking to me. And he ended up with a gigantic intracranial hemorrhage. And of course, once that happens, you're obligated to stop everything, right? You got to stop his 2B3A, you got to stop all his antithrombotic therapies. And then about 4 hours later, he had anterior ST elevation as well. So he was sort of stuck rolling snake eyes in this particular clinical situation, and unfortunately passed away. And it was at that time, in about 2000, so at the end of that academic year, that I went to the DCRI. And my mentors at the time were Jamie Jollis and Bob Harrington. And they said, what do you want to work on? I said, well, I'm interested in learning a little bit more about this issue of bleeding and whether we can come to a way of treating patients to minimize bleeding risk but also reduce ischemic events. And they said, that's the dumbest idea I've ever heard in my life. But just to tell you that this is still a current issue, this is a case that was sent to me by Abdullah Rabiz, who runs the cath lab at the American University of Beirut. He and I were fellows together, and he sent me this case. This is an 81-year-old female who came with a non-STEMI. She has some risk factors that we all see in our patients every day. Very focal, clean, 90% mid-right coronary lesion, got a stent. It was very successful, no post-procedure CKMB elevation, so this is not a periprocedural MI. But she'd end up with a groin hematoma that was sizable, but unfortunately, because of her risk factors, had a fever to 38.5 the next day, eventually developed a necrotizing groin infection, and then died. So this is the picture that he sent me. And so this is a situation where the operation was successful, but the patient died. So this is hopefully many of us will go our entire career without seeing something like this. But it was cases like this that led me to sort of think about 4 hypotheses that I wanted to explore during my research time. I was pretty convinced, just because of my own clinical experience, that bleeding was relatively common. And just given the way we were treating bleeding complications, or the way we reacted to them, I thought that it would be reasonable to hypothesize that it was associated with an increased risk for mortality and morbidity. We also, as through discussions with a lot of my mentors, thought that maybe the risk of bleeding would increase with the acuity of the clinical presentation. In other words, patients who come in with stable angina may have a very, very low bleeding risk because they're outpatients, they tend to be healthier, whereas the patient with primary PCI, or those who are in shock, may have a higher risk. There was this whole issue around blood transfusion, and I'll tell you a little story about that when I get to some of the data that we've looked at. We weren't convinced that blood transfusion was the way to go. What I learned in medical school was that you can't transfuse myocardium, but you can always transfuse blood. But what happens to the red blood cell during the storage process, we were pretty convinced actually didn't mitigate the risk that's associated with bleeding. And then ultimately, if we were able to prove some of these hypotheses, we thought that strategies that reduce bleeding will ultimately improve outcomes. Now, I was very lucky because at the DCRI at the time, we had multiple randomized clinical trial databases, all of which had bleeding complications that were adjudicated. So these are trials that had acute coronary syndrome patients who underwent PCI. Many of the trials had similar inclusion-exclusion criteria, so the data could be pooled relatively easily. And using data from 4 trials, about 26,000 patients, we wanted to look at the incidence of in-hospital bleeding complications during treatment and subsequent outcomes. We found that about a third of the patients had some kind of a bleeding event. The majority of it was mild, according to the Gusto scale, but about 10% of the patients got a transfusion, so a bleeding event that resulted in a transfusion, and 1.2% had a bleeding complication that was was associated with hemodynamic compromise or was intracranial hemorrhage. Now, these are all non-ST elevation ACS patients. So when was the last time you saw a non-ST elevation ACS patient who had an ICH? It's pretty unusual. But at that time, this is early 2000s, given the potency of the antithrombotic therapy we were using, it was about 1.2% of the patients had an ICH, so pretty significant. And there was a stepwise increase in the risk of 30-day mortality as the bleeding complication severity increased. Now, again, it's probably not a surprise that severe bleeding that leads to hemodynamic compromise or ICH is associated with mortality. What is surprising is that even these mild bleeding events, sort of in this green line here, were associated with an increased risk of mortality, and that was curious. Now, we certainly didn't think that groin hematomas killed people directly, but we were interested in sort of understanding how to explain this finding. And if you look at the landscape of PCI in the United States right now, which is using the NCDR data, the most common complications patients have now is bleeding. Now, we're all worried about recurrent ischemia, we're all worried about heart failure, everyone's talking about shock all the time now, but these are relatively rare complications. I mean, in the NCDR data set, shock in a non-ST elevation ACS patient is about 1.8%, but bleeding complications are around 5.5%. Similarly for STEMI, shock is about 4.5%, and that's expected, patients who come in with large anterior MIs, but the bleeding rate's twice that. So bleeding is still the most common complication that occurs in a patient undergoing PCI in the United States. And what we also found was that because of our data sets that we had multiple bleeding definitions. And we could figure out what bleeding definition actually mattered. And so not to be too cynical about this, but the first time I met Neil was actually when we were talking about planning a trial with bivalirudin and a novel low molecular weight heparin at the time that we were working on. And we were actually struggling with trying to figure out what the bleeding definition should be because, again, not to be too cynical about it, but let's say you're evil drug company A, okay? And you're pretty sure that what you have is way more potent than what's out there. You may construct the bleeding definition in your clinical trial so that a patient has to practically bleed to death before it, quote, counts. That makes the bleeding rates very low, right? Now, let's say you're evil drug company B, and you're pretty sure that what you have isn't that much better than what's out there, but maybe it's a lot safer. You're going to count every single drop of blood that comes out of that patient as a major bleeding event, because then the rates become really high and maybe you can show a difference. Now, I'm not really saying that people do that, but you can understand the risk. So in our data set, we had 2 different definitions of bleeding in these trials, TIMI bleeding and Gusto bleeding. The details are not all that important. TIMI bleeding is really dependent on whether your hemoglobin changes. Gusto is more of a clinical definition. And we found that depending on what definition you used, you could actually dial in or out the rate of bleeding complications in your trials. Now, this was a surprise at the time. Definitions at the time were really focused on trying to define MI and trying to adjudicate stroke, but this whole issue around bleeding definitions was something that was relatively new, and it was a little bit shocking to people that you could actually game the rate of bleeding depending on what the bleeding definition was. So we got together with a bunch of people, sat in a room, a lot of people who like the sound of their own voice, including myself, but we did hammer out something called the BARC definition of bleeding. This is the Bleeding Academic Research Consortium, which has actually become the default bleeding definition that's been used in clinical trials now. And I think it's at least a step forward in trying to standardize definitions for trials of acute coronary syndrome and percutaneous coronary intervention, because at least then we're all talking the same language. Now, if there are any statisticians in the crowd, you may be cringing because we're not supposed to compare across trials. But at the bedside, that's exactly what we do, is we try to figure out what the best treatment for the patient is. And without some kind of standardized definitions, it's almost impossible to figure out which option to go with. So the BARC definition, I think, was an important step forward in trying to standardize bleeding definitions. Of course, the Academic Research Consortium now has developed a lot of definitions for different settings. There's VARC for valves. There soon will be my favorite acronym, SHARC, for shock, so stay tuned for that. So I think we were pretty successful in showing that bleeding was relatively common. I mean, a third of the patients developing bleeding is pretty high. But who are really the patients that are at risk? And several groups around the country, not just ours, have shown that as the acuity of the clinical presentation increases, the risk of bleeding also goes up. But not only that, the proportion of bleeding events related to the vascular access site also changes. So for example, a patient who comes in for an elective PCI with stable angina as an outpatient has a very, very low risk of bleeding in general. Okay? But the vast majority of their bleeding events are related to the vascular access site. On the other hand, a patient who is admitted with non-ST segment elevation acute coronary syndrome has a higher risk of in-hospital bleeding, but interestingly, only a third of those bleeding events are related to the vascular access site. And then the patient who comes in with a STEMI has the highest risk of bleeding, and again, it flips again, 3/4 of those bleeding events are related to the vascular access site. So why is any of this important? It becomes important when you start thinking about bleeding avoidance strategies. So if you have a bleeding avoidance strategies that addresses access site bleeding, you're going to have the biggest bang for the buck in the STEMI patient because they have a high rate of bleeding and the vast majority is related to the vascular access site. And this becomes important when we start evaluating some of the randomized trials of radial versus femoral access. These are data from Ron Waxman's group, a really nicely done study looking at 23,000 patients, looking at bleeding outcomes, again, showing the same thing. This is the TIMI definition of bleeding. The patients who are at highest risk are those with STEMI and those with STEMI with shock. So again, if you're going to show an effect of a bleeding avoidance strategy, it's probably going to be in the STEMI patients. And I want you to keep that in mind as we start talking about some of the data. What about this whole issue of blood transfusion? I spend part of my professional life thinking about the physiology of blood transfusion. I'll tell you a story. So I was a cardiology fellow, and I had 2 kids then, and they're both toddlers, and I remember my wife tells me, put them in the bath or whatever, so I got them in the bath, and I got a page from the hospital operator, and the hospital operator, the message on the pager was, please call Dr. Califf. Now, many of you know who Rob Califf is former commissioner of the FDA. When you're a fellow and you get a call to call Dr. Califf, you have to call Dr. Califf. So I tell my wife, just watch the kids in the tub. I got to answer this page. And so Rob was calling me, and he said, I understand you have some data on transfusion. I think transfusion is bad for people, and I want you to help me prove it. Now, the data that we had on transfusion, I had spent some of my time as a fellow looking at Medicare managed care. Some of you are old enough to remember Medicare managed care. We were pretty convinced that the reason that they were able to save so much money was that they were cherry-picking their patients. So completely unrelated to any of the stuff that I'm talking about. But I spent 6 months of my fellowship loading data into this computer. It looked like these are 8-track cassette tapes. Some of you are probably old enough to remember 8-track cassettes. That's what they look like. And when we spit out the data, the number one procedure that the Medicare population was getting billed for was blood transfusion. It was more common than getting a head CT in this patient population. I was stunned. And right around that time, the TRICK trial had come out, which is the randomized trial of transfusion strategies in critical care. So I thought this might be a nice opportunity to examine the association between blood transfusion and outcomes. Now, when we look at the literature on blood transfusion, it's very interesting. You can think of the patient as half full or half empty. There is something called the 10-30 rule, which I learned when I was in medical school. That is, if the patient has ischemic heart disease, you have to keep their hemoglobin at 10 or their hematocrit at 30. Anyone know where that comes from? So it's a study done in 1945 at Duke by Jim Warren, who ultimately became the chair of medicine at Ohio State, and Gene Stead. I don't think you can do this study anymore, but what they did was they took medical students and gradually bled them down. And they put Swan-Ganz catheters in them, probably without informed. I suppose if you wanted to get an A, you probably had to sign up for the study. And they measured cardiac outputs, and they found that once their hemoglobin hit 10, can you imagine how much they bled these students down? Their cardiac output went up. And so they said, okay, that's a maladaptive response. This is what our trigger should be. And you can certainly find data to support that trigger. A lot of it's observational data. There's that 1945 study. There's a study from the Cooperative Cardiovascular Project, which is a Medicare study in 2001, showing that in patients who are admitted with acute MI, their mortality increases if their hematocrit is less than 33. On the other hand, you can find plenty of data to show exactly the opposite, which is that patients tolerate very, very low levels of hemoglobin. Particularly studies in Jehovah's Witnesses, for example, show that some patients tolerate hemoglobins as low as 6 after bypass surgery. And so when you have this kind of disparate data, you really have equipoise. And despite that, there are about 12 million units of blood transfused annually in the United States. And in fact, in the US, in acute coronary syndrome patients, there's a tremendous amount of variability in transfusion across sites. Xin Yang was a medical resident at Duke when he did this study from the old Crusade database, showing that some hospitals don't transfuse any of their ACS patients, and some hospitals transfuse over 28% of them. Similarly, in the PCI population, this is Matt Sherwood, who is a fellow with us, is now at Inova in Virginia, showed that in patients undergoing PCI, some hospitals don't transfuse anybody, and some hospitals transfuse over 8% of the patients undergoing PCI. And again, these are not randomized data, so you have to be a little bit careful. This is observational data. But when you look at these studies, there is an association between the use of transfusion and an increased risk for adverse events. And that relationship holds down to a hematocrit of 25 or a hemoglobin of 8. So, the critical care literature, all the trials have been 7 versus 9 and shown that maintaining a hemoglobin of 7 is non-inferior to 9. In the cardiac literature, particularly for ischemic heart disease, that trigger may not necessarily be 7, it might be 8. And the reason I say 8 is that there have been 3 studies independently showing, again, observational, that there is an inflection point of adverse outcomes at a hemoglobin of 8, not 7. So it's interesting. We did a pilot trial at the VA called CRIT pilot, just to show feasibility of a transfusion trial in ACS patients. We randomized patients 8 versus 10. It was very challenging to enroll in. And the reason is that patients don't stay in the hospital to get anemic anymore. And the average length of stay for a non-STEMI is around 2 days. And then Jeff Carson in New Jersey used stimulus funding to do another pilot study called MINT, also looking at feasibility, 110 patients. And so using the pilot data from those 2 trials, we applied to the NHLBI, and Jeff Carson is the chair of this trial called the MINT trial. This is the big MINT. I tried to convince Jeff to call his pilot study Junior MINT, but he doesn't share the same sense of humor that I have. So this is a 3,500 patient trial. We're about 1,500 patients into this enrollment. These are patients with ST elevation MI or non-STEMI who are anemic at any point during their hospitalization. Hemoglobin less than 10, they get randomized to maintain a restrictive strategy, which is maintain a hemoglobin of 8, versus a liberal strategy, which is hemoglobin of 10, and the primary outcome is 30-day death or MI. This is a notoriously difficult trial to enroll in. Again, patients don't stay in the hospital long enough to get anemic anymore, so the kinds of patients that are getting into this trial are very elderly patients. They have multiple comorbidities, cancer, COPD, CKD. These are very, very sick patients. So we had to recalibrate the kinds of patients we're enrolling in ACS trials. This is not an industry-funded drug A versus drug B where it's a healthy executive with a non-STEMI. These are very, very sick patients. So the event rates are going to be high. We hope to report this trial in the next 2 years. But again, all the sites that are enrolling in this are really doing yeoman's work here and trying to get patients in. So I think, as the landscape has changed in acute coronary syndrome management and in PCI, this is really what we're looking at moving forward for the development of these strategies, which is that if you're only worried about thrombosis and you're not worried about bleeding, you're really just treating half of the patient. And I think that many of you, particularly who are in training, are aware of this paradigm now, that you're trying to minimize the complications across the board, not just ischemic events, but also bleeding events. So that all sounds great. I mean, bleeding is bad. I mean, it's probably obvious now. Transfusion may be bad, so that's not an insurance policy. But what can we actually do to reduce those risks? And does reducing that risk ultimately improve outcomes? So again, this is the last hypothesis, which is that strategies that reduce bleeding will improve outcomes in ACS and PCI. So when we start thinking about strategies, it's important to think about mechanisms, right? Because then we can tailor what our strategies are. Now, the most obvious mechanism here is confounding, because these are all observational data. It's very difficult to randomize patients to bleeding versus no bleeding. Although you'd be surprised, there actually is a trial of that. Anyone remember the FEAST trial? You guys remember the FEAST trial? The FEAST trial was a trial that was in patients with symptomatic PAD. They had claudication. And the hypothesis put forward by the FEAST trial investigators was that claudication was caused by iron overload. So they needed to randomize patients to iron reduction, that's phlebotomy, versus usual care. And over 12 weeks, they bled patients down a couple of units of blood, and you won't be surprised that there was no difference in the outcome between those 2 trials. That's the only trial that I know of, aside from maybe every July in the cath lab, of bleeding versus no bleeding. No offense to any fellows here. But let's see if we can get beyond confounding. Certainly severe bleeding, we can all agree that if you bleed into your brain, that's probably bad. But again, that's decidedly rare. I mean, it's unusual for us to see ICH. It's unusual for us to see, huge hematomas and retroperitoneal bleeding. Probably what we're seeing most of the time now is what we call mild or moderate bleeding. And the joke, of course, is that the definition of mild bleeding is a bleeding event that happens to someone else. But think about this in a very, very simplistic way. if someone has recurrent ischemia, we generally intensify therapy. If someone has a bleeding event, we're really obligated to stop everything, right? There's nothing else we can do. And that's probably the mechanism by which some of these adverse events occur. It's a cessation of evidence-based therapy that leads to that outcome. In fact, there's a very nice paper by my colleague Tracy Wong showing that in patients with acute coronary syndrome who experience an in-hospital bleeding event, they are significantly less likely to be discharged on dual antiplatelet therapy. But even at 1 month, 6 months, and 1 year, they're not put back on it. And that's probably has to do with the fragmentation of care in our system. We've already talked a little bit about blood transfusion. So what can we do? Well, certainly we can try to identify who's at risk, right? So there are published bleeding models that are validated and try to tailor our therapies to those higher risk patients. I'm one who's argued that probably every patient is at risk. It's just a matter of degree. Judicious use of blood transfusion, we'll get more data on that from the MINT trial. Pharmacotherapy, lots of money spent on trying to figure out strategies to reduce bleeding risk. There still is a belief that one day we'll find an anticoagulant that will reduce ischemia and not cause any bleeding. I have yet to see something like that, but it doesn't stop us from trying. And then, of course, there's vascular access. I'll spend some time talking about radial approach. So there is a way to identify patients. There are two calculators that are available both for iOS and for Android. I worked on both of these. This is when I was the chair of the SCI Quality Committee. We came up with a Pci Risk Calculator based on the Blue Cross Blue Shield of Michigan data set. It's a very, very robust models because it uses what's called random forest models to figure out the discrimination of these models. It's actually a very good app. It'll give you the simultaneous risk for a patient for both contrast-induced acute renal injury, transfusion, and death. And then the Cath PCI bleeding risk calculator is also available. That's based on the NCDR bleeding risk calculator. So both of these can be used at the bedside to calculate a patient's risk of bleeding. I'm not going to talk much about pharmacotherapy. I think that if people are interested in discussing the whole issue around heparin dosing or bivalirudin, certainly that's worth a conversation. But what I am going to pivot now to is vascular access site strategies, and that's radial approach. So when I was a fellow in 2003, 2004 in the cath lab, I did a grand total of 2 radial cases. One was successful, the other one I couldn't get access. And I remember I finished my fellowship on a Friday, I had the weekend off, and then I was an attending starting Monday, and I was on call that night. And I was on call with Frank Zadar, who's Jim Zadar's brother. Frank is now at Austin Heart, and he had trained at the Cleveland Clinic for his general fellowship, and the third STEMI that came in that night was a lady with an occluded aorta. And I looked at him and I said, oh my God, we're gonna have to do this from the wrist. And he said, I've only done 3 of these. I said, I've only done 2. But we figured it out, and that's when I decided, okay, I should start doing one radial case when I'm in the lab, just so I'm comfortable. And then when I would get up at meetings and talk about my research into bleeding, there was always some person in the back that would raise their hands and say, if you're so interested in bleeding reduction, do you do radial approach? And I'd have to admit, no, I'm really not doing it. So we started thinking about, what are the data on radial access, and why is it that it hasn't really caught on in the US at that time? If you look at the randomized trials that were before 2009, this is basically the world's literature. And only one of these was done in the US. Tift Mann did this. Tift Mann, many of you probably know, had built a practice in Raleigh, North Carolina. He retired about 2 years ago. He was the first person to do a randomized trial in the US of radial versus femoral, fewer than 150 patients. And so Sanjit Jolly did this meta-analysis and then decided to do the rival trial. But we wanted to look at the radial landscape in the United States. So we looked at close to 600,000 procedures in the United States using the NCR data set between 2004 and 2007. And again, this is observational data. We found that there was a strong association between the use of radial access and a reduction in bleeding or vascular complications compared with femoral approach. No reduction in procedure success. But despite these data, the use of radial access in the US at that time was 1.3%. 99% of the procedures were being done via femoral access, and it was absolutely flat between 2004 and 2007. There was no change whatsoever. Now, around that time, Sanjit launched the rival trial, and I was fortunate enough to be the national coordinator for the US in the rival study. Many of you remember the rival trial. It included both patients with non-ST elevation ACS and STEMI undergoing ACS management. They were randomized to radial versus femoral access. This was a sub-study of the current OASIS 7 trial. So it had to use the same bleeding definitions and the same outcomes as that trial. And the primary outcome was a composite of death, MI, stroke, or non-CABG-related major bleeding. The definition of major bleeding in this trial was very, very restrictive. In other words, if you bled and required 1 unit of transfusion, it didn't count as a bleed. If you bled into your eyes but you didn't go blind, it didn't count as a bleed. So these are really big, bad bleeding events, okay? And I remember, so the US participated in this trial. The problem with the US at the time was that you had to have done at least 50 transradial PCIs in the year prior in order to qualify as an investigator. So we had very few sites in the US, and out of 7,000 patients, we put 180 patients into this trial. So very, very few. And I remember the night, I think it was ACC when he presented this as a late-breaking clinical trial, when he was unveiling the results, he said that follow-up in this trial was 99.9% complete. 1 patient out of 7,000 odd patients was lost to follow-up, and it came from the US. So, 180 patients, we lost someone to follow-up. So I leaned over to Gabriel Steg, many of you know Gabriel Steg from France, and I said, boy, that's really embarrassing. We put very few patients into this trial, and we're the ones who lost someone to follow-up. And without missing a beat, he said, that's the risk you take when you do trials in third world countries. So what did we find? Well, surprisingly to many of us, we didn't find a difference in the overall composite endpoint. And we also didn't find a difference in major bleeding because the bleeding event rates were so low. And remember, 2/3 of the patients in this trial were non-STEMI patients. And remember what I told you at the beginning of the talk. The vast majority of bleeding events in a non-STEMI patients are unrelated to the vascular access site. So there's really no way this trial would have shown a difference with vascular access. Now, when we looked at major vascular access site complications, which is a much more sensitive way of picking up access site strategy outcomes, we showed a significant reduction, over a 60% reduction in that with radial access. So this is just one of many trials that have been done in the STEMI population. It's also been shown to be beneficial. We were curious, why are US operators not picking up on this? So we did a survey of 200 interventional cardiologists in the United States. And what we found was that there were 2 big issues. The first was that there were no US-based trial data. US interventionalists would look at the rival trial and they would say, that's not the way I do business. In the US it's totally different. You can't do that. So there was a lot of appetite for a US-based trial. The second was that there were no training opportunities post-fellowship. We had an FDA think tank at the White Oak campus at the FDA. The FDA was interested in radial access at the time because they thought that the labeling for every single antithrombotic agent said that there was a risk of bleeding. And if they could show that radial approach reduces bleeding risk from these different antithrombotic agents, maybe they could alter the label or at least inform the label. And again, it was open to the public, it was open to industry, it was open to NIH. Everybody said, you got to do a randomized trial. Okay, how hard can that be? Let's do a randomized trial of radial versus femoral. It turns out it's actually really hard. And the reason is that in order to have a fair comparison, you have to have operators with radial expertise. Those radial operators are unwilling to randomize to femoral. The femoral operators are unable to randomize to femoral just because they're not proficient enough. So we had to come up with a patient population where a radial operator can, with all honesty, go into a patient's room and say, you know what, I don't know what's better. So we had to come up with a patient population and an endpoint that the radial operators would buy into. The second thing is that radial approach is not a fancy gizmo, it's not a drug. Who's going to fund this trial? And so that was another challenge. We had to do the trial in a very, very cheap way. So around that time, Bob Harrington, one of my mentors, had gotten funding from the NIH to develop what was called the NCRI, the National Cardiovascular Research Infrastructure. What this essentially was to build randomization on top of the NCDR Cath PCI registry. The idea was born from a comment that Rob Califf had made years ago, which is, our hospital participates in this registry, so we have someone comes in and they take all the data from a patient and they put all that data into a computer. And then if that patient is in a randomized trial, some other person comes along and takes all that data and puts the same data into another computer. Like, why are we paying 2 people to do the same thing? Why can't we take all the data from the registry and just use it to populate randomized trial data? So that's exactly what the NHLBI did with NCRI, and at the end of that grant period, there had to be a randomized trial that was being done. And so Bob was kind enough to let us do what was called the Safe PCI for Women trial, where we built this on top of the NCDR. So let me show you how this worked. So this is done in women. So a woman would come in, they would be consented for randomization into this trial, radial versus femoral. They would undergo their procedure, and as part of the routine workflow of the site, all the data is getting into the NCDR anyway. The back office software that was developed through NIH funding would then take all that data from the NCDR and auto-populate the clinical trial case report form. And we were using Oracle at that time, inform. And so when the study coordinator for the trial went to fill in the data on the case report form, 60 to 70% of it was already done. And all they had to do was fill in the data on the outcomes. Now remember, in trials, you pay for time. And we were able to reduce the amount of time the study coordinators were spending entering data, because again, most of the case report form was already auto-populated with NCDR data. We had one site who actually didn't participate in the NCDR, and they also just entered all the data manually. Now the other problem that we had in launching this trial was to find proficient radial operators. Now look, I filled out these site questionnaires. I'm sure you have too. We all lie on those things, right? I mean, you know, you're going to do a trial of AFib and PCI, and they ask you how many patients with AFib underwent PCI at your center last week. You say, oh, I think it was about 50 of them, I think. All right? And one of the things about U.S. operators, we all do the most complex cases, and none of us have any complications. So the joke was that if a U.S. operator tells you how many radial cases they're doing, just take that number and cut it in half, because they're really not doing that many. But with NCDR, we had a way of actually identifying who was doing radial cases. We didn't have to rely on site questionnaires anymore. And so these are the data that was spit out. We actually asked the registry, what sites are doing at least 20% radial in women? And so the first 60 sites were our sites for the trial. And of the 65 sites that we used, 3 had never participated in clinical research before. So, and this is the trial that we did. It's called the Study for Access Site for Enhancement of PCI in Women, the Safe PCR for Women trial. This is still the only randomized trial in interventional cardiology ever done solely in women. Amazing. You know, it's actually kind of a sad commentary. But we randomized women undergoing cardiac catheterization, urgent elective PCI, or cath, to radial versus femoral. We had 2 primary endpoints. This is the way the radial operators bought into this trial. The first was what we call the efficacy endpoint. So what's the efficacy of radial approach? Is to reduce bleeding, right? So the efficacy endpoint was BARC types 2, 3, or 5 bleeding or vascular complications. And then we had what was called a primary feasibility endpoint, which was access site crossover. Females tend to have smaller radial arteries. The risk of crossing over to the femoral approach may be higher. And this is how we got radial operators to buy in. We had a series of secondary endpoints as well. These are the data. We did show a 70% reduction in bleeding complications at a risk of about a 6.7% access site crossover. I presented these data at TCT, and TCT that year was the first time that you could ask questions through the app that they had for the conference. And as a late-breaking clinical trial presenter, you were on stage, and they had these huge screens behind you where people could comment while you were presenting, which is very intimidating, because they could say, you know, Rao's tie is crooked, or I mean, they could say all kinds of things. And one of the comments that came up was, oh, the reason that the crossover rate was 6.7% in this trial is because US operators don't know how to do radial. But I will tell you, it's lower than the crossover rate in the rival trial. So if anything, we're maybe better than some of the operators in the rival trial. But the more important thing about this was how we did the trial using this registry-based randomized trial concept. We randomized 1,800 women, got 30-day adjudicated outcomes for a grand total of $5 million, which is pretty remarkable, because Neil and I worked on a phase 2 trial of an anticoagulant that had 600 patients, and it cost $35 million. So this is really, we've saved a significant amount of money, but the more important thing from a site perspective, remember, when you do a randomized trial, 80% of your patients come from 20% of your sites. Some sites never enroll a patient. In this trial, 96.7% of sites enrolled at least 1 patient, and 70% enrolled at least 10 patients. So we're able to prove that the registry-based randomized trial concept worked, and at the same time, we're able to show that radial approach reduces bleeding risk in women. Now, it's important for us to talk about the latest data, Safari. So Safari trial is a labor of love by Michel Lemay. Give him a lot of credit for this. The randomized trial data in the STEMI population shows that radial approach actually reduces mortality. Remember what I told you at the beginning of the talk, the patients who are going to benefit the most from radial access are probably going to be the STEMI patients. They have a very high risk of bleeding. Most of the bleeding is related to the vascular access site, and bleeding is associated with an increased risk of death. And sure enough, in at least 3 trials in the STEMI population, radial access has reduced mortality. So Michel Lemay didn't believe it, and I think it's good to be skeptical, and launched a Safari trial in Canada. I think he had 4 centers in this trial, I can't remember exactly, but he randomized patients with ST elevation MI undergoing primary PCI to radial versus femoral with a primary outcome of 30-day mortality. Very ambitious trial. One of the few trials that has mortality as a primary outcome. Unfortunately, he was unable to finish enrollment. He had planned to randomize 4,484 patients. He had to stop at about 2,292. just wasn't feasible to continue anymore, largely because of funding, and then because of the endpoints, the event rates were so low. The data are there for you to look at. You can see that there's really no significant difference in all-cause mortality. While there is a separation of curves with bleeding, it didn't reach statistical significance. Now, to his credit, when he presented these data at the ACC, he included the Safari trial in a meta-analysis of all the other trials in STEMI that have been done. And even if you include the negative or neutral Safari study, there is an effect of radial access in the STEMI population reducing mortality. Now, what's the mechanism of that benefit? Is it all bleeding? I don't know. I mean, you'd have to assume that every patient who bled in these trials died. I'm not sure that's a reasonable expectation. So the mechanism still eludes us, but the Matrix trial investigators, which is another trial that showed a reduction in mortality, tried to do something interesting. You know, in this randomized trial of radial versus femoral, there was a strong relationship between radial access and a reduction in post-PCI kidney injury, which is pretty curious. And even after adjusting for volume of contrast, the effect was still there. Now, people have hypothesized maybe it's because you're not traipsing up and down the abdominal aorta, you're getting less atheroembolic events, who knows. But in this really interesting study, they tried to look at the mechanism, the probable mortality benefit, and they say it's not the fact that patients have a reduction in bleeding, it's the fact they have a reduction in post-PCI kidney injury, which also is associated with increased mortality. It's interesting, you know, I'm not sure that it probably needs to be validated in some way, but it is an interesting additional benefit of radial access, and not just reducing bleeding risk. So what about the second barrier, no training opportunities? Well, I think this has largely gone away. I mean, there have been multiple training opportunities now through the professional societies, through various hospital systems. On the upper left-hand corner is the 2011 radial sessions at TCT. We had one room, the crowd spilled over into the hallway. They had to add 2 more rooms. You know, in the old days, the radial session was always the last session of the last day. But I think there's been a tremendous amount of interest now from the clinical community in trying to learn this. It turns out that the radial learning curve is actually not that high. I think previously it was felt that you had to do like 100 or 200 cases in order to become comfortable. Connie Hess, who is a fellow with us, who's now at the University of Colorado as an interventional attending, does this really elegant analysis from the NCDR where she took each operator who was a new radial operator, in other words, they had done no radial cases in the 6 months prior, and compared that operator to themselves over time. And what she found is that the inflection point for fluoroscopy time and contrast volume is around 30 to 50 cases. So the learning curve, depending on how proficient you may or may not be, is not that high. It's only about 30 or 50 cases, which for many people can be achieved within 6 months. What's happened with radial growth in the US? Well, unfortunately, the NCDR doesn't report radial cases anymore. They stopped with the latest version of the NCDR, which is version 5. So I have outdated data. These are data that Dimitri Feldman at Cornell looked at through 2011. Remember, I told you it was relatively flat between 2004 and 2007. Starting about 2008, 2009, with the publication of the Rival trial, or participation in the Rival trial, rather, and some of the observational data that had come out, there was an inflection point. It started increasing pretty significantly. And the second quarter of 2018, which is the data that I have, which is the latest data, it was about 40% of all PCIs in the US were being performed by a radial access. This past year, the VA system nationally crossed the 50% line. So we're about 55% of all the PCIs in the VA system are being done by a radial access. We've asked NCDR for the latest data. Again, they're not routinely reporting this, so it'll be interesting to see if we've crossed the 50% mark nationally outside the VA system. Certainly, I think as proficiency has increased, we realize that we can use radial access for all kinds of complex procedures. This is a case that we did a couple of years ago, distal left main trifurcation in a patient who was turned down for surgery, 6 French left radial access, balloon pump support. I think a very acceptable result with the culotte technique in the distal left main. We do biradial CTOs as well. Certainly we use femoral access when we have to and use 8 French, but our rate of radial access at our center is about 96% now. Certainly the professional societies have caught on, and the AHA was the first to say that a radial access approach is preferred in patients with acute coronary syndrome. The revascularization guidelines are being updated, so time will tell to see what the combined revascularization guidelines will give radial access. We just don't know yet. And the VA system has become very, very interested in radial approach because they're interested in reducing procedural risk for veterans. So through VA HSR&D, we got a grant to increase the rate of adoption of radial access in the VA system nationally. We're able to identify which centers in the VA are doing less than 10% radial, and they were randomized in a, not really randomized, but they were enrolled into this study in a step wedge design So, which is a radial proctoring program. They attend a course. We actually go out and spend a couple of days with them, and then we touch base with them every week or so to see how their radial access program is going. And we just wrapped up the last set of sites, and we're analyzing the data now. Hope to report this in the spring. The ACC also has decided that reducing bleeding risk is a priority. They've launched something called the Reduce the Risk PCI Bleed. On the right-hand side are all the centers in the U.S. that have signed up for this. This gets you a toolkit that not only gives you order sets that you can plug into your EHR, but also comes with access to the risk apps, and then reports back to the sites that are participating their rate of risk-adjusted bleeding as well as their rate of radial access. And if sites are interested in getting more radial training, they can reach out as well. Now, one of the things that people have talked about is, well, if we start doing all this radial access, what happens to our femoral skills, right? And I think that's a reasonable thing to be worried about. There was something called the Campo paradox, which is reported by Lorenzo Azzolini and the group at Montreal Heart, where they showed that in their population of patients at their hospital, the more radial cases they did, the higher their risk of femoral complications. So Jim Nolan and I were privileged enough to write an editorial to that, and Jim is part of the United Kingdom BESIS registry, where they looked at the same question in the BESIS registry. And what they found was interesting. In an unadjusted way, sites that do a lot of radial have a lot of femoral complications. But after adjustment for the fact that the patients who are getting femoral access are the ones who are in shock and require mechanical support, it turns out there's absolutely no increase in risk. In fact, in the UK, the safest place to get a femoral stick is actually at a high-volume radial access center. And the reason is that they're very keyed into vascular access site issues. They tend to use a lot of ultrasound for access. The BMC squared data are very, very recent. These are data from the state of Michigan, showing also a similar kind of thing, which is as their adoption of radial increases, there's a slight uptick in femoral complications. These are hospital-level rates. And the overall rate of adoption in the state of Michigan is around 45%. Amit Vora, who is a fellow with us, is now in Harrisburg, looked at hospital level of adoption of radial access and reduction in bleeding, and it turns out that you have to have at least 85% use in order to reduce hospital level bleeding risk. And the reason is that once you're at 85% or higher, the risk treatment paradox goes away. In other words, you're treating all the patients with radial access, even the high risk ones. What we've noticed in the registries is that the patients who are at highest risk for bleeding are the ones who are least likely to get radial access, unless you have a radial first approach to these patients. Now, certainly, I've talked about in-hospital bleeding risk. Bleeding risk has now shifted to the outpatient setting. We're talking about shortening duration of DAPT because radial access really does solve in-hospital bleeding, but long-term bleeding is still an issue for patients who get coronary stenting. And so we're looking at ways to reduce that long-term bleeding risk. One is to reduce the duration of dual antiplatelet therapy. The other is new stent platforms. So the LEADERS-FREE trial, for example, and LEADERS-FREE 2 with a novel stent that's what they call a drug-coated stent that you can get away with 1 month of dual antiplatelet therapy. The ARC group, of which I was privileged to participate in, has come together to define high bleeding risk. So this is really to inform clinical trial work. If you're going to study high bleeding risk patients, these are the characteristics you should be looking for. All of the major stent manufacturers have now done randomized trials or observational studies with historical controls of shortened DAPT. So hopefully we'll have more information on how to reduce bleeding risk post-hospitalization. Now I'm going to take a little bit of a left turn here and talk about something a little bit crazy. So in 2017, I gave a talk at the Sky Fellows course, and a couple of fellows came up to me and said, Dr. Rao, you're not on Twitter. And I said, no, that sounds like a bad idea. And they said, no, that's how we're getting information now is through Twitter. And I actually had joined Twitter when Twitter first came out because my dad, many of you remember the terrible Mumbai train station bombing that happened. The news of that got out through Twitter before the major news outlets got wind of it. So my dad had heard this and said, hey, you got to get on Twitter. It's this great thing, and you can follow me. I was like, okay. So I got on Twitter, started following my dad on Twitter, and I realized that my dad was tweeting things like, I'm now drinking coffee. I am watching TV. So I said, okay, life is too short. I can't do that. But then, I had this idea after the fellows talked to me. I said, when I give grand rounds or I give a talk to the fellows, I'm talking to the people in the room and maybe whoever they're streaming to. But Twitter has an international audience. And so with a lot of people that I'd collaborated with in the past, we decided to launch this thing on Twitter called #RadialFirst. For those of you who don't know, hashtags are a way to categorize tweets on Twitter. So you can search by hashtag. And we said, well, we have a lot of information on our own slide sets about how to start a radial program, how to solve problems, what the data are. So why don't we just start tweeting using this hashtag and put out all the data that we have on our slide sets to everyone who's maybe interested. And amazingly, it sort of took off. In order to sort of become an official hashtag, you have a certain number of mentions, and we met that threshold within 48 hours. And we're just about to crunch the data for 2019, 2020, but this is as of last year, 2 years after inception. We've had 7,000 unique users. We've had over 120 million people interact with a tweet that uses hashtag Radial first. And in fact, it's been amazing, the international reach of this thing. There are people in the South Sudan tweeting cases with hashtag Radial first. I didn't know they had cath labs in the South Sudan. But they're doing complex cases via radial access, and they're teaching people about how they're doing it using Twitter. So it's a very powerful medium. Certainly there are risks associated. I think we're all familiar with what some of those risks are. But as an educational meeting, it has a tremendous amount of power, and it's a tool like anything else. And lest you think it's just something to take up your time, there has been some academic productivity out of it. There was someone who posted about door-to-balloon time delay if you're doing radial access for primary PCI. Now, the guy on the right-hand side didn't really believe that we should be doing radial for STEMIs. He thought that this was radial extremism. But it did lead to this paper that Bobby A., Ajay Kirtane, and I wrote in JAMA Cardiology about how to incentivize radial approach for primary PCI. Perhaps we should be giving sites that are starting to do transradial STEMIs a little bit of leeway in terms of door-to-balloon time until they become proficient. The other thing that's been introduced via social media is this concept of distal radial access, which is first actually developed in Russia, but Ferdinand Kimene has been a big proponent of this. And it may be that this is the new way to go. We're worried about radial artery occlusion and its subsequent use as a bypass graft and for AV fistulas, but maybe distal radial access in the snuff box can prevent proximal radial occlusion, or distal radial occlusion. Sorry, proximal radial occlusion. So it was just announced yesterday on Twitter, Karsten Schenke is doing a randomized trial called Correct Radial, which is randomizing patients to distal radial access versus traditional proximal radial access and looking at radial artery occlusion. So this has led to some academic productivity. So I think that, we have to figure out the right way to use social media. We have to figure out how this may play into the adoption of new procedures. Radial, I think, is just one case study in this. But there are all kinds of things that are being used now. There's hashtag CTO 101, where people are using Twitter to talk about CTO techniques. There's hashtag Echo First to talk about non-invasive imaging. So with that, I'll wrap up and have time for some questions. I think we were interested in this because we were interested in in-hospital post-PCI bleeding complications. And I think the data are pretty clear now that it is associated with an increased risk of morbidity, mortality, and costs. So we are really obligated to reduce both. After all of the study over the past decade, it appears that radial approach is really the single most effective way to reduce bleeding risk. And it continues to evolve. I mean, we're talking about distal radial access now. We're talking about radial artery preservation because there are data emerging that it's better for bypass grafts, and obviously we're worried about patients who may get AV fistulas. So we need to continue to study that. And now we're shifting our focus on bleeding risk from the in-hospital setting to long-term follow-up on antiplatelet therapy. So I think that it's still going to be something that we're going to be talking about for the next 10 years. I do want to thank some of the folks who worked on all of these data. It's certainly not my own work. Rob Califf, Bob Harrington, and Eric Peterson, who are my mentors, and these are the many fellows that helped us with all of these data. So I want to thank you again for this kind invitation. It's really been an honor to present in front of you, and I'm happy to take any questions if you have any.
All right, Sunil, that was really a fantastic presentation. And again, I think it just kind of highlights how when you have an idea as a fellow and you keep working on it and taking it through, that you can make a career out of this. And I think that's very inspirational for the fellows as well. So we've got some time for questions. Let me start off with one quick question. I think you showed very nicely that radial approach seems to be the preferred way to go. Now, I'm curious though why that's not being tracked any longer. Because you would think one of the ways that you ensure that you're using best practices is to track it, and I'm curious why that's not being tracked.
Yeah, I don't think it's a deliberate thing by the ACC. I don't know for sure. I think what's happening though is that they're shifting the way they're actually reporting the data back to sites. I think they're focusing a lot more on sort of the hospital metrics that are necessary for quality improvement rather than things that perhaps may be of interest to individuals. They will report them to you if you ask them, but it's not part of the standard report anymore.
Great. And then Dr. Kleiman?
So, great talk.
Wait, Neil, use the microphone.
Sunil, great talk. So, there are 1,000 questions that I could ask, but I'm going to limit myself.
To 500.
Yeah, right. So I'd like to get your perspective on two things, because we all know that there's a lot of nebulousness here.
Yeah.
So first of all, when we first started talking about bleeding, from then to now, I've never been able to get my arms around confounding.
Yes.
Just because you know who bleeds, I know who bleeds, even the non-interventional people know who's at risk to bleed, and these are also the same people who are at risk to die.
Right.
So risk is risk, regardless of what it's the risk of. If you're at risk for one thing, you're at risk for everything.
Absolutely, yeah.
And then number two, I'm going to ask you to give us an in the trenches perspective of femoral closure devices.
Yeah.
Because those are they're always casting a shadow on this discussion.
Yeah, absolutely. So, I agree with you. I think that, observational data comparing radial versus femoral is hopelessly confounded. And I think we've moved beyond that. I mean, there have been over 22,000 patients, just ACS patients now, randomized in trials comparing radial versus femoral. So now, I mean, if you're going to try and say something about radial, you really got to do a randomized trial. So the issue is, are the randomized trial data believable? So the bleeding, of course, so there are a couple of things, phenomena that occur when you do a randomized trial. And we learned this through the Safe Pci for Women trial. We actually published on this, which is you can't blind it, right? So when operators or site investigators know that bleeding is the primary outcome, remarkably, their femoral outcomes improve. So we actually showed this. When we looked at sites in the Safe Pci for Women trial, and we looked at patients that were in the trial versus not, patients in the trial had better outcomes than patients not in the trial. So that's one issue, is that femoral outcomes tend to get better when a patient is in a randomized trial. So the bleeding complications, you can potentially game that with the way you adjudicate it, the whether you're checking the hemoglobins, et cetera. What you can't game, though, is death. And that's what I think has been the biggest source of confusion even for radial enthusiasts like me, which is you're seeing now 3 trials that have shown a reduction in mortality with radial access. It's hard to game that. And so why is the mortality rate lower? So I agree with you. There is confounding, but I think it's balanced by the fact that there is this quantitative interaction of therapeutics, which is the higher risk you are, the more benefit you get. So you're right. Patients who are at very high risk for bleeding are going to be at high risk for death. They tend to be frail. I would argue that they're the ones who probably have the most to benefit from radial approach. But it may also be the hardest to do radial access in those patients. So closure devices are interesting. Almost all the observational data show that closure devices reduce bleeding risk. There isn't a single randomized trial that shows the same thing. In fact, the biggest randomized trial of closure devices is ISAR closure, which is in diagnostic coronary angiography, and it showed that it was non-inferior to manual compression. The one thing that it does do is it reduces time to ambulation, which radial access also does. So, I think vascular closure devices are great for reducing time to ambulation. They're great when appropriately done for large bore access. But I'm not convinced that as a routine strategy, they actually should be included in any kind of bleeding avoidance strategy, because we just don't have randomized trial data to show that that's the case.
Dr. Earl, that was phenomenal. I'm a friend of Jerry Levy's, and he said to welcome you. Said you'd give a great talk, and indeed you did not disappoint. So I'm a surgeon, and we think of bleeding as a function
Nobody's
of,
perfect, yeah.
Yeah, nobody's perfect. That's good. But we think of bleeding, bleeding is accepted. Now I will say, why is it accepted? Why is it ever tolerable? And we think of it in 3 categories. Bad technique. I would say not using ultrasound guided access. It's an example of bad technique. We would fire our residents we don't stick any blood vessel anywhere, anytime, except in emergency without using ultrasound. Remarkably difficult to get that to penetrate the other specialties. Number 2 is bad technology. For us, making anastomosis, it doesn't work. And the third basic is bad disease.
Yes.
And, when you compare the femoral versus the radial, if you don't have a difference in bleeding with those 2 approaches, there's something wrong with that trial.
Yeah.
You can't put 2 units of blood into your forearm near as easy as you can put it into your groin. So, it's amazing there's not been more penetration. I mean, how you get it to penetrate more that trial's been run in the lower extremity with atherectomy. No data works. Pay people a fortune for doing it. Transformation overnight. In 6 months, you'll completely change basically what the approach is. And so if you show there's an improvement in mortality, what are the strategies other than running training programs to get people to use this more?
It's a great question. You know, in the UK, the private insurance company, which is called Bupa, actually pays physicians about £200 more if they do radial access. Access is bundled into our payments for PCI. So I actually had a conversation with CMS about 2 years ago when Patrick Conway was still running the CMS Innovation Center. And I talked to a very, very nice physician who works for CMS. She was great. She said, this sounds like, we should be incentivizing this financially, people doing more radial. It sounds like it's kind of like laparoscopic surgery. We could add a V code. But I need you to know that it's all bundled in. So you'd have to unbundle the vascular access. Then you'd have to get a code for radial approach. And then she said, now I'm not trying to tell you what to do, but I have to tell you, it's a finite amount of money, which means that if you're going to pay more for radial, you're going to pay less for femoral. You might want to think about how that is going to affect your career. And so I said, oh, okay, the message received. but I think you're absolutely right. And what's been amazing, even at our center, is the people who have the lowest vascular complication rate from femoral access is our surgeons, because they use ultrasound all the time, routinely. Now, it's considered a quality metric in our ICUs for venous access, so it's always been confusing to me why it's not a quality metric in the cath lab. So if you think the adoption of radial is low, the adoption of ultrasound for femoral access is even lower. And now, there are ways you can potentially get paid for that, but again, that's not why we do things, or it shouldn't be why we do things. And so we've now tried to encourage all of our operators and our fellows to routinely use ultrasound access, regardless of radial or femoral, not because it's needed for radial access, just because we want them to be used to using it as part of their workflow.
The dilemma of triple therapy.
Yeah.
Somebody with atrial fib comes with STEMI. You have to use oral anticoagulant and dual antiplatelet.
Yeah.
Is there any good consensus about how to do it nowadays and to decrease the bleeding issues?
Yeah, so great question. This sort of gets at post-procedure bleeding complications over the long term. And I think, the pooled data from all the novel oral anticoagulant trials suggests that really dual therapy with the oral anticoagulant and a P2Y12 inhibitor is the way to go. There is a slight uptick in stent thrombosis rates in the first 30 days. There have been 3 meta-analyses that have all shown that. It's not a dramatic increase, but it's certainly higher in the first 30 days. So I think most people are probably doing at least 30 days of triple therapy in very, very high-risk patients. So left main bifurcations, maybe some CTOs, STEMIs, and then at that 30-day mark, maybe even some people are doing for up to 3 months, dropping the aspirin. We can talk about whether aspirin's been unfairly demonized, but certainly the trials have shown that if you have the dual therapy strategy, oral anticoagulant plus P2Y12, it reduces bleeding risk compared with triple therapy. So that's what our strategy has been.
All right, well, we're a few minutes over time, so once again, a big round of applause for Dr. Rao for an outstanding presentation. All right, very nice.
Very good. Pleasure to meet you.